So it just produce or release T4, thyroxine hormone, and triiodothyronine, T3, which works to work in regulation of the metabolism, energy level, heart rate, and body temperature. So during their function, they usually require iodine to produce these hormones. That's how it is. They just utilize iodine to produce these hormones. So embryologically, the two thyroid lobes, they develop from autobronchial bodies of the phospharyngeal arches during the phospharyngeal arches bodies during the first week of gestation age, but it fully function at around 18 to 20 weeks. Yeah. Okay. These parafollicular cells, they usually derived from neurocresty series. The gland is bilobed. It is encapsulated with two lobes, right and left, and it weighs approximately 20 to 25 grams in adult, and it is fresh and pinkish in color. So the upper bone reaches the oblique line of thyroid cartilage. The lower lobe reaches the 6th tracheal line, but the isthmus overlie only between the 2, 3rd, and 4th tracheal line. So this gland, thyroid gland, anteriorly, it is covered by petechial fascia. Posteriorly, it is covered by carotid sheath. And there is a special point which make white thyroids have movement on the deglutitions, because this posterior fascia thickening, sometimes we call it ligament of belly, anchor the gland to the cricoids and tracheal rings. Yeah? That's why you usually have movement on the deglutitions, because of this ligament of belly. So we have two extensions also on the thyroid gland. We call lobulated pyramids, which is extension of the gland in the most anterior part, and the processus pyramid, which is a cranial extension along the isthmus, yeah? Along the isthmus. So histologically, thyroid gland consists of the follicle, segmental follicles, which are now the functional units, this segmental follicle. They are filled with a gel-like mass. It's called colloids, yeah? So these segmental follicle, they are lined by two types of cells. These cells are the one which are lined in the segmental follicle. We have follicular cells which secrete thyroid hormones, and the follicular cells which secrete calcitonin. So anatomically, in relationship by cutting along the C7 at the axial section posteriorly, it is surrounded by prevertebral fascia, as you see on the picture below, carotid sheath, parathyroid, and the trachea. But medially, it is surrounded by laryngeal nerve, tracheal, larynx, and esophagus. While anterior, there is a petechial fascia, stenohyoid, sternothyroid, and venous artery. You can see on the demonstration of the picture below here. So the blood supply mainly is from superior thyroid artery, which is a branch of external carotid artery, and also the inferior thyroid artery, which is a branch from the thyrocervical trunk, which is derived actually from the first part of subclavian arteries. The venous is actually mainly major vein drain. The thyroid gland is the superior thyroid vein, which drain internal jugular vein, and the middle thyroid vein drain in internal jugular vein. Also in inferior thyroid vein, it's draining on innominate veins. Yeah? This lymphatic drainage also is from the petechial, which is something called delphic. Yeah? Petechial and perilaryngeal, they pour it in deep cervical, supraclavicular, also mediastinal lymph nodes. So the nerve supplies sympathetic innervation from cervical plexus, but parasympathetic, which is come from the vagus nerve. You can see the demonstrations of the picture here on the right side. So let's come to the physiology of the thyroid gland. So what is happening is this hydrogen peroxide generated by thyroid peroxidase traps the iodine, which in turn combined with tyrosine, a residue of thyroglobin. This tyrosine is a residue of thyroglobin and free tyrosine. They formed tyrosine in T4 and T3. So actually, the release of this thyroid hormone, it is mediated or it is influenced by thyroid stimulating hormone, which stimulates the follicle cell to reabsorb thyroglobin, cleave, and release the hormone into the blood in binding thyroid binding protein. That's how it is. So as we stated before, the major function of this is just to increase the basometabolic rates, to increase conditions, metabolism like lipolysis, proteolysis, Also to increase the motility of GIT due to the increased smooth muscle tone, to augment sympathetic activity in the body, to optimize the brain development and the functions. So after looking on the anatomy, introduction and embryology and anatomy, let us go now to the disease of the thyroid glands. So the disease, most thyroid disease of the thyroid, most of them lead to the enlargement of thyroid gland. So the term we call it goitre. So it is applied. This same goitre is applied to the enlargement of thyroid gland, regardless of the cause. That's how it is. So this disease can be classified into different categories by using this schema you see downward here. Thus, disease of the thyroid can be inflammatory. Thus, we can have an acute, subacute, and chronic. Can be toxic, that can be primarily or secondarily. Can be neoplastic, that you can have benign and malignant. Can be autoimmune, those are things of Hashimoto thyroiditis or dethyroiditis, but also can be simple, like physiological or colloidal or nodular. So other ways, these goiters can be classified according to the clinical pathological presentation, like epidemiological goiter, like when you're having endemic goiter, sporadic goiter, or familial goiter. But also can be classified into the aspect of morphological, how they present morphologically, like diffuse, nodular, which can also be multinodular or solutal nodular, but can be also classified into functional aspect as toxic or non-toxic goiter. Also, sometimes you can classify them based on the location, like you have a cervical or neck, or we have retrosternal or interthoracic goiters. So let us now cover now on a simple goiter. So whenever there is a chronic deficiency of T4 and T3 in the body, which in turn will cause a compensatory elevation of TSH because of the lack of necessary negative feedback. Now this a prolongation or stimulation of TSH release because of this chronic deficiency T3 and T4 in attempting to bring normal thyroid hormone is the one which can lead into simple goiter. So this phenomena can be seen to conditions like where there is iodine deficiency, when there is the environmental or physiological conditions, like for instance in a pregnancy, when there is enzymatic deficiency, enzymatic deficiency disease like Pandro's disease, those who are having deficiency or peroxidase deficiency, when there is dietary iodine deficiency inhibitor, we call it goitrogenase. For instance, this is called aminosalicylic acid. It's called para-aminosalicylic acid, called PAS. These food contents. They are dietary iodine binding inhibitors. So when they are there, these conditions can result into simple goiters. So epidemiologically, we're starting Uganda. Unfortunately, we couldn't get the current data regarding these goiters, simple goiters. But the study which was done by having retrospective study, which was done by Cardozo LJ in 1974, it showed that through this 5-year retrospective study of thyroid disease in Uganda hospital, it showed that about 67% of the cases are due to the goiter as hyperplasia, with colloid diffuse goiter, twice as much as common as nodular goiter. But also a study which was done by Bimenya, GS 2004, just was looking on the impact of iodine, iodine deficiency on goiter, by looking at the distribution of visible goiter rates among the school children in district in 1999 compared to that of 1991. So it was comparing between 1999 and to that of 1991. Overall visible goiter rate decreased by 9.2%, whereby individually, Kabale, Kapcholo had significant fall of 14.7% and 20.1% respectively. Thus, Kabale was 20 and this 14 was, Kapcholo was 20 and Kabale was 14.7. Now, Hoima, Kisola had a slight significant increase in visible goiter rate respectively by having 4.4, another 7.2. This suggesting severe iodine deficiency in the later 2 districts. So that's how it is. This according to the Upper Kilwero had no previous data. These Upper Kilwero districts, they have no previous data. This is just a graph to demonstrate by comparing 1999 and 1991. You can see the study which was done by, I'm sorry for sorry, yes, 1991, 1992, by a study which was done by CCB Benya GS. So globally, according to WHO 2022, iodine deficiency is still the leading cause of preventable goiter. It affecting 2 billion of people worldwide, including 244 million school-aged children. Goiter prevalence in the region is with severe iodine deficiency can reach up to 30 to 50% of the population. So simple goiter can be classified as follows. These are just the types or just classification of simple goiter. That's why having this is called simple diffuse goiter, which is characterized by the uniform enlargement of entire thyroid gland without any nodule. The gland, you will see the gland is very smooth and diffusely enlarged. There is no nodule in a simple diffuse goiter. So another one is called simple colloid goiter, which where you're going to see the gland is enlarged due to the accumulation of colloids. This colloid is just a substance which is a substance which is stored, which is a substance which is stored here. The substance in which this thyroid hormone is stored within the follicle. Okay, so the gland may be spongy, gelatinous in ecosystems. Sometimes these colloid goiters are often more common in an area with iodine deficiency. But also we have simple nodular goiter. This is quite different because it is characterized by the presence of one or more numbers of nodules. Some we can call it multinodular goiter. But with time, these simple diffuse goiters can change and become nodular. So all of these types, simple diffuse, simple colloid goiter, simple nodular goiter, but also can be retrostenoid, can have retrostenoid extension. That is sometimes we call it anatomical subtype because of clinical significance. So pathophysiologically, simple goiter, as I've said before, just a chronic absence of T3, which causes elevation of TSH, which leads to the diffuse homogeneous hypertrophy and the aplasia of follicular cells and the colloids in effort to produce more thyroid hormones. So what's happening now in differential response to TSH, there will be formation of more nodule within the gland. So severe nodule coalesce can lead to the formation of multinodular goiter. So this nodule may secondarily undergo changes, they may undergo changes like central necrosis, cystic changes or degeneration, hemorrhage, calcification, and by only 3%, they may change into malignant. By only 3%, may change into. But in about 30% of the patient, a very huge goiter may secrete excess hormone and lead to the secondary pathologism. Now, this is not considered as a simple goiter. When it turns into the huge goiter and secrete excess hormone, we don't consider it as a simple goiter. We don't consider simple goiter. So, how does this simple goiter present clinically? You're going to see a gradual ascent of painless until the next swelling. Are you getting me? Am I audible? Hello?
Continue.
Yes, sir. Yeah, yeah.
Okay, thank you. So, gradual onset of painless neck swelling, recent onset pain, increase in size may indicate secondary changes. Whenever they usually having swelling which is painless. But when you see the pain, it means the nodule has undergone some changes, as I've said before, is a calcific or hemorrhagic, whatever it is. So, and this enlarged gland may also affect the enabling structures and cause obstruction of the airways. So patient can present with difficulty in breathing, wheezing, coughing on lying spine. Sometimes it may cause obstruction of the esophagus, dysphagia, or neck vein obstruction, which can lead to the fascial congestion. Sometimes we call it theora. So likewise, the congestion of the neck and the face vein and superior vena cava syndrome is huge in little stenogoiters. So this now, superior vena cava syndrome tend to be worse when the patient lays arms above the head. This sign we call it the Pemberton sign. That you're going to see this superior vena cava syndrome tend to be worse when the patient lies in arm up. That's we call Pemberton sign. It's a clinically. So investigation to be handled in simple or to be done in simple goiter. It's just a normal thyroid function test. We need to measure the level of thyroxine T3, T4, and the TSH. So this will help to know if the thyroid gland is normal or is it hyper, or is having hyper or hypo functioning. So also you can do this is called thyroid scan with radioactive iodine. We're using iodine 123 or iodine 131 in investigating. What is actually done, we just inject this traceable radioactive iodine, or sometimes we call technitum, to inject into the bloodstream. Then what's happening? You just inject it. So it goes through the bloodstream to the thyroid gland. Will concentrate over there? Then what's happening? This concentrated iodine now can be detected by taking a gamma. This is a gamma camera, or sometimes we call it a scintillation counter. You take a picture over there. So sometimes we prefer this iodine 123, 123 more than 131 because it has short half-life. It has short half-life. And sometimes this thyroid scan, they can show nodules. These nodules, which take more radioactive iodine than the rest of the gland in secondary hyperthyroidism. However, most simple goiter, they have no uptake of cold nodule, which does not take radioactive iodine. So something to note is like this. The cold nodules are like to be malignant. The cold nodule are like to be malignant. So another test which you can do is this called antithyroid receptor antibodies, which is just an investigation to the patient who are suspected to having autoantibodies, stimulatory antibodies, as in case of grave disease in primary hyperthyroidism. So radiologically, you can do this normal anteroposterior or lateral X-ray, which may demonstrate lithosteno or retrotracheal extension of the goiter, but also rule out other chest problems. So also you can do this thoracic inlet X-ray to look for the or that will enable you to see for the compression or deviation of the trachea. And this is very important if surgery is contemplated, just in case of difficult intubation for those anesthetists. So also you can do this CT scan, may be indicated if surgery, it may be indicated before surgery if you suspect malignant transformation. Also, you can do this called FNAX, fine needle cytology. This is very important investigation to rule out malignance of thyroid. That can be malignant, suspicious malignant, benign, inconclusive, whatever it is. Something to note, when you do FNAC and the follicular pattern is seen, then you have to do lobectomy, and you have to do lobectomy to exclude this follicular carcinoma. You do lobectomy and you send that tissue for histopathology because the follicular carcinoma can be detected by demonstrating capsular inversion. This is a very important point. Whenever you suspect a follicular pattern, you do lobectomy, you send it for histopathology to see if there is a capsular inversion to rule out this follicular carcinoma. So the medical management of simple goiter, just observation and monitoring. If the goiter is small and symptomatic, then in regular monitoring by doing some physical examination, thyroid function testing. You can do periodic or interval ultrasound like this. But also the second one, which you can do as part of medical management, is iodine supplementation. Is iodine supplementation. This can be supplemented by in cases where iodine deficiency is high. You just do iodine supplementation. This can help to reduce the size of the goiter by achieving this dietary change in supplementation. Thus, dietary intake, just when you recommend dietary intake by taking like iodized salt, seafood, dietary products, like that. So another investigation is called thyroid hormonal therapy. I mean, another management treatment, medical management of thyroid in simple goiter. Thus, you provide some levothyroxine, can be prescribed just to suppress the TSH. Though by suppressing the TSH, I mean it is TSH level, thyroxine hormone level, it can help to shrink the goiter in some patients. That's how it can be done. But also, you can try to avoiding goitrogenous substance like food, like this having cabbage, broccoli, and soy. Those can be avoided to reduce the risk of goitrogenic substance, may help to manage the condition also. So we have this called iodine therapy, in some cases, to those patients who are not good surgical candidate or who they refuse surgery at all. Yes, you provide them with low dose of radioiodine therapy. That also can help to shrink or to reduce the size of the goiter. So surgical management of simple goiter, first of all, let us know the indication of surgery into simple goiter. If you're having a larger goiter causing compression syndrome, whether it's tracheal or esophageal compression, if you're suspecting malignance, or if there is the presence of nodule within the goiter that have suspicious features of imaging or biopsy, if you're having a lithostenous extension of the goiter, that could lead to the further complication. But also, you can do surgical management for cosmetic concern, especially. You see the patient having the goiter is large and visible. So for cosmetic purpose, you can opt to do thyroidectomy. So a type of surgery that can be done is total thyroidectomy to remove the entire thyroid gland. But this is only recommended if you suspect a cancer, or it is a large multinodular goiter, or if the goiter is causing significant compression. But you also can do subtotal thyroidectomy to remove the thyroid gland, leaving a small portion of the tissue intact. This is the option we prefer. This may be an option to those who prefer to avoid the lifelong thyroid hormone, because when you are doing total thyroidectomy, it means you are going to subject the patient, going to put the patient on lifelong thyroid hormone replacement therapy. So those who are trying to escape from this, they are just doing subtotal thyroidectomy. But also we can do this is called hemothyroidectomy, sometimes called lobectomy. Just you remove the lobe of the thyroid gland. Yeah, you remove the lobe of the thyroid gland. That's how it is. So what are the postoperative complications? Postoperative complications. Yeah. So the patient, those who are undergone total or subtotal thyroidectomy will often require lifelong thyroid hormone. But we need to have it's not a complication. This is the postoperative consideration. What are you considering after doing this total thyroidectomy? Total thyroidectomy, subtotal thyroidectomy, they have to be subjected to lifelong thyroid hormone replacement. But also we need to plan to have a good level of follow-up with thyroid function testing, or possible imaging to monitor the recurrence or residual disease is very important. So let me welcome my colleague to this. Later we can discuss on this thyroglosal system.
Yeah, good evening, Professor. Good evening, colleagues. I'm Dr. OSBERT, taking you through the same topic. Let's discuss thyroglosal cysts. So thyroglosal cysts is a fibrous cyst that forms from a persistent thyroglosal duct remnants of the embryonic development. As we've already gone through the embryology, we've seen that the thyroid gland embryologically originates from the third arch, and it goes with the thyroid. It descends into the anterior aspect of the neck, leaving this duct along its line of passage. This duct ideally is supposed, once the thyroid reaches its right position in the anterior neck, it's supposed to obliterate and degenerate. However, in some proportion of people, this tract does not obliterate. It usually obliterates around the 10th week. So if it does not obliterate, it persists, forming a persistent thyroglosal duct. That extends right from the foramen cecum at the base of the tongue, right down to the thyroid gland. So the thyroglosal cysts are typically located in the midline of the neck, often just below the hyoid bone. However, they can occur at any point along their course or migration of the thyroid gland. So their exact locations may include the base of the tongue or any other position along that path of migration. So these thyroglosal ducts may end up into cysts. Once they get accumulated with fluid, they form cysts. Usually these cysts are found near the hyoid bone, but can also be found anywhere along the path from the foramen cecum at the base of the tongue, the thyroid gland. So the thyroglosal duct cysts are present in about 7% of the population. They have an equal preponderance between male and female. So it's not, you can't say it's more dominant in females on there. No, it's equally distributed. Although they are known to be mostly pediatric masses, they are often present in adults at varying frequencies. There are about 20-25% present at the level of suprahyoid, 15 to 20% present at the level of the hyoid, and 25 to 65% present in the infrahyoid levels. So symptoms. So as we've said, this duct may accumulate free to become a cyst, and so they usually as once the cyst is not infected, it's usually painless. It's a movable lump in the anterior neck. Most common, soft, smooth. It moves upwards with swallowing, and especially if you want to be sure it's the one, you ask the patient to protrude the tongue, and you see movement of this anterior neck mass. Then, which is evident that it's attached to the base of the tongue. It will also move on swallowing. So once this cyst gets infection, it will form an abscess. So once it forms an abscess, as usual, as any other abscess, there will be redness, tenderness, and swelling. The infected cyst may form an abscess that can rupture and drain through the skin, forming a fistula, which will be chronically discharging. So it may be associated with difficulty in swallowing or breathing. Large cysts can cause difficulty in swallowing, especially with the inflammatory, once they get infected or due to mass effect. They may cause difficulty in breathing, dyspnea, and usually due to pressure symptoms, but it also depends on where they are exactly located. So clinically, on the diagnosis, we may have a clinical assessment. You can be able to diagnose this cyst. As we already said, once you ask someone to protrude the tongue out, you'll see it move. Once you ask people to swallow, you'll see it move, and it's usually in the anterior aspect of the neck. Then on imaging, ultrasound is typically the first imaging modality used to evaluate the cyst and its relation to the surrounding structures. Our CT scan and MRI may be used to further evaluate it, where there is a concern for complications to the plan of surgery, or even when you are planning your surgery, your surgical intervention, you want to see the related structures and the surrounding vital structures that you may have to go through. Then fine needle aspiration. In some cases, fine needle aspiration may be performed to rule out other pathologies, though it's not typically required for straightforward cases of thyroglosal cysts. So this may be done, but it's not a must that it must be done. Surgical treatment. So the only treatment is surgery. The definitive treatment is surgical excision, or the procedure is the cyst trunk procedure, and is the standard surgical method, which involves the removal of the cyst, the tract, and the central portion of the hyoid bone to reduce the risk of recurrence. The procedure includes excising a core of tissue around the cyst up to the base of the tongue. So you have to excise the entire tract right to the foramen cecum, where it originates, to be sure that it will not recur. In general, the procedure consists of 3 steps: incision, dissection of the cyst and hyoid bone, and drainage and closure. As we saw on the right, there are several versions of the cyst procedure, and they include the classic which looks a little more invasive. This is with the excision of the center of the hyoid bone along with the thyroglosal duct cyst. Remove of 1/8 inch diameter of the hyoid bone at 45 degrees angle to the foramen cecum to include mucosa. Remove of 1/4 inch of the center of the hyoid bone, closure of the cut ends of the hyoid bone, and replacement of the drain. So there are also modifications to this. So the modified, we do dissection through the tongue base, but not through the mucosa. The modified cyst trunk procedure is a procedure of choice in both primary and revision cases. Then for the young, where the cartilage has not ossified, we may have cartilage, hyoid cartilage division with the monopolar bioelectric cauterization or scissors. However, there are no statistical differences between those modified cyst trunk and the conventional cyst trunk procedure. So antibiotics, if the cyst is infected, antibiotics may be required prior to surgery. If the abscess is present, it may need draining. Then follow-up, we need follow-up to monitor for recurrence and any other complications as it involves dissection of the hyoid bone. It could be associated with injuries to the associated tissues and other complications such as loss of voice and recurrence of the cyst or fistula. So complications, the most common complications are recurrence of the cyst, especially if the entire thyroglosal duct tract has not been removed. Then infections, recurrent infections can occur particularly if the cyst is not completely excised. Then thyroid cancer, though rare, constituting about 1% of thyroglosal duct cysts, may contain thyroid tissue that can become malignant, most commonly papillary thyroid carcinoma. Already said it's a tract through which the tract connecting the thyroid gland, right from its migration from the foramen cecum, the anterior neck, this anterior neck position. So some tissue, thyroid tissue, may be retained in this tract and could end up into malignant. So the other thyroid tumors, the benign and malignant. So thyroid tumors are normal growth or masses that form within the thyroid gland. They may be malignant or benign. The burden of the disease. Globally in 2020, the estimated number of new cases of thyroid cancer was 449,000 in women and 137,000 in men, corresponding to age standardized incidence rates approximately 10 to 1 per 100,000 women and 3.1 per 100,000 men worldwide. That's according to Global CAN 2008. Prevalence of this cancer in 2021, they were an estimated 979,285 people living with thyroid cancer in the United States. That's according to the American Society of Clinical Oncology. Risk factors for thyroid tumors. So people who have increased exposure to radiation have increased risk for thyroid tumors, especially in childhood. Then genetic factors, family history of thyroid cancer or genetic syndromes such as MEN2, familial adenomatous polyposis, Cowden syndrome, they increase the risk of thyroid cancer. Iodine deficiency, of course, iodine deficiency results into will consequently result into higher TSH levels that will stimulate the hyperplasia of the locally infiltrate the area. So as we continue, thyroid adenomas are benign, non-cancerous tumors of the thyroid gland that arise from follicular epithelial cells. They are usually solitary, encapsulated nodules that can vary in size and function. Most thyroid adenomas are non-functioning cold nodules. That means they do not really produce any thyroid hormones and do not produce, but some can be functioning. So those which produce thyroid hormones are hot nodules, and those which do not are called cold nodules. And as previously said, cold nodules have higher chances of malignant transformation, whereas hot nodules are usually innocent. So types of thyroid adenomas. So we have follicular adenomas, of course, arising from the follicular cells. It is characterized by well-encapsulated nodule composed of follicular cells that resemble normal thyroid tissue, but are arranged in different architectural patterns. It does not invade surrounding thyroid tissue or exhibit any malignant features. So the moment on histology, the patterns, the arrangement patterns of the follicular cells is distorted, we start thinking of follicular adenomas. So subtypes of follicular adenomas, we have the fetal adenoma. As you look at the pictures on the right, they are composed of small, densely packed follicles that resemble the fetal thyroid. Then we have embryonal adenomas. These contain microfolliculi that are less densely packed than in fetal adenomas. Then we have choroid adenomas. These consist of large choroid follicles that resemble normal adult thyroid gland. Then we have Hutho cell adenomas. These contain cells with abundant eosinophilic pink staining cytoplasm. And this subtype is sometimes considered separated due to the distinct cytological features, as you see it over there in the right. So clinical presentation. Thyroid nodules, how do they present? Patients with thyroid adenomas often present with a solitary nodule that may be discovered either incidentally or on physical exam. At times they are not seen until we do imaging, depending on their position. So symptoms of hyperthyroidism. In the case of a functioning thyroid adenoma, or which we call toxic adenoma, or the hot nodules, patient may present with symptoms of hyperthyroidism, such as weight loss, palpitations, heat intolerance, resting tremors, and significant weight loss, among others. So in the case of large adenomas, there may be compression symptoms, such as in swallowing, or there may be hoarseness of voice in case the laryngeal nerves are compressed. How are these diagnosed? So as previously stated, We can diagnose them on physical examination. If you are examining of the thyroid gland, because this is ultrasound gives you most of what you may need to see, and it's less invasive and more available. Then fine needle aspirate. This is performed usually for those which are suspicious and should ideally be ultrasound guided. Usually for all, if there is diffuse enlargement of the thyroid, we usually fine needle aspiration may be optional, but for nodular goiter or for any other suspicious nodules, it's highly advised, as nodules have a higher chance of malignancy transformation. Then radioactive iodine scanning. Here, radioactive iodine is administered, and using a gamma scan, we can be able to see the hot nodules, which will absorb most of the iodine, and we therefore have higher radiation emissions. Cold nodules have higher risk of malignancy, but they may not be very evident. So observations. So in the treatment, there's what we usually call watchful waiting. So if there are no marked symptoms, and usually the anomalies are small with less suspicion, we can monitor them regularly and follow up with ultrasound scan, see whether they are innocent or they are really aggressive. Thyroid hormone suppression therapy. As we said, these nodules usually are due to stimulation by the thyroid stimulating hormone following low levels of T3 and T4 in saturation. So when we administer synthetic thyroid hormones like thyroxine, there's a negative feedback which suppresses TSH secretion, and hence the nodules tend to shrink. Then radioactive iodine therapy may be used for treating toxic adenomas, especially in patients who are not candidates for surgery. There are some patients who are, especially if they have thyroid, if they have goiter with cardiac symptoms and are not suitable for operation, or for any other cause or their preference, they don't want surgery, they use radioactive iodine. Then surgical removal. This is indicated for symptomatic adenomas, those causing compressive symptoms, those with suspicious features suggesting malignancy. Then thyroid.
Then after looking on now we are discussing about thyroid tumors. After looking the benign conditions, benign tumors of the thyroid, let us also see all these malignant thyroid cancers. These are relatively uncommon, but they represent the most significant category of thyroid tumors due to their potential to spread, but also cause serious issues. So generally, they can be classified into like 4 or 5. We have this is called papillary thyroid cancer, follicular thyroid carcinoma, medullary thyroid carcinoma, and anaplastic thyroid carcinoma. Papillary thyroid carcinoma, this is the one which is more common by having more than 80 to 25% of all cases. It is typically arise from follicular cells, and actually it presents with a painless thyroid nodule, which can spread to nearby lymph node. But the good thing is that it has a good prognosis, especially in young patients. How do we manage this? Is by doing surgical removal, that's we call thyroidectomy, which is followed by radioactive iodine therapy to eliminate the remaining thyroid tissues or metastatic. This another one is called follicular thyroid carcinoma. This one also raised from the follicular thyroids, but it has it is not common. It's not common comparing to that is a papillary. It's having only 10 to 15% of the cases. As I've said, it's arising from follicular also, but it is very aggressive compared to that of the follicular one. And it can spread through the bloodstream to distant organ like lung and bone. And this one is the one which is very common in an area with in the region we see iodine deficiency. How do we treat it? Is by doing thyroidectomy with possible radioactive iodine therapy, similarly as we did on papillary carcinoma. Another one is called medullary thyroid carcinoma. This it's account only for 5% of all thyroid cancer. It's the one which is arising from parafollicular cells. Remember, the last two was arising from follicular, but this one is from parafollicular cells. It can be sporadic or familiar, and usually it presents with thyroid nodule and the elevation of calcitonin. So remember, these parafollicular cells are the one which are secreting calcitonin. So how do we treat them? Is by doing thyroidectomy with central neck dissection. But unfortunately, this one, they don't respond to radioactive iodine compared to the papillary and the follicular. So another one is called anaplastic thyroid carcinoma. This is account only 2% of thyroid cancer. It is a highly aggressive form of thyroid cancer, and it's usually occurring in older adults, and it has poor prognosis compared to the other type of cancer because it has rapid growth and early metastasis. Often it presents with enlarging neck mass, causing compression symptoms such as difficulty in breathing and swallowing. The treatment option may include surgery, radiotherapy, and chemotherapy, but the overall survival rate remains very low compared to the other types of cancer. Another one, which you can say is other form of thyroid cancers, like this is called the hepatothyroid carcinoma. It's just a variant of follicular carcinoma that is very aggressive, but this one is different from that follicular carcinoma because it doesn't respond to radioactive iodine, while the follicular cell carcinoma responds to radioactive iodine after surgery. Another one is called the thyroid lymphoma, which is also a rare form of the cancer. Also, it arises from the lymphocytes, which are in the thyroid gland. It may be associated with some conditions like Hashimoto's thyroiditis. The treatment is typically through chemotherapy and radiotherapy. So how do we investigate thyroid cancer? The investigation of thyroid cancer, the investigations to patients who are suspected to have a thyroid cancer is, as we saw previously, by doing thyroid function test first. Then you do fine needle cytology. This is very essential to establish the malignant, and always done on thyroid neoplasm. And this is just a schema of fine needle aspiration cytology, what has been done. That's the only exception is to the follicular adenoma, which should always follow by lobectomy. Then you send the tissue to the histopathology to exclude the corpuscular and vascular inversion features, which are typical feature of follicular malignancy. Thus, you see this schema. Thus, you are doing fine needle aspiration, biopsy. Well, if it's a malignant, you do surgery. If it's intermediate, then you can do radionuclide while you are assessing. If it's cold, surgery. If it's warm, like that, you do surgery. If it's cold or warm, whatever it is. Or you can do fine needle and find it's benign. If it's benign, then you can make follow-up or just follow up with radionuclide. But if it is hot, you do follow up until when it's cold, then you can opt for surgery. This is just a scheme on how one is be done on FNAC. But as I've told you, lobectomy, it is followed. It is mandatory to those who are having follicular because you need to send it to exclude the corpuscular and vascular involvement. So chest X-ray is very important to rule out retrosternal extension in lung metastasis. And all other thoracic inlet X-ray are necessary to establish tracheal compression or deviation. So sometimes you can do bone X-ray to rule out bone metastasis, especially to medullary carcinoma of the thyroid. This is the one which mostly causes osteolytic lesion. Yes, this one medullary carcinoma. It causes osteolytic lesion, but also osteoblastic lesion of the bone. Yeah. So you can do abdominal ultrasound to rule out, to try to exclude the liver metastasis also. CT scan is very important. CT scan of the neck or chest or abdomen to establish the extent of the tumor. You need to see the extent of the tumor, especially in larger tumor. In this way, the nature of surgical intervention can be contemplated. So also you can do indirect laryngoscope to those patients who are presenting with hoarse voice to establish the baseline of the findings. So how do we stage the thyroid cancer? We just use the normal one that we call it TNM. That's tumor size, lymph node involvement, and the metastasis. That by having TX, if a tumor cannot be accessed, T0, if there's no evidence of primary tumor, T1, if limited to the thyroid, 1 centimeter or less, T2, if it is limited to the thyroid, 1 centimeter less than, or 1 centimeter less than 4 centimeter. T3, if it is limited to the thyroid, but more than 4 centimeter. But T4, if it's just beyond the thyroid capsule. On the lymph node involvement, we use NX if you cannot assess if there is no lesional lymph node. You cannot assess lesional lymph node, yeah. But you also, if there is no lesional lymph node metastasis, we use N0. But N1 if there is a lesional lymph node metastasis. But in the aspect of distance metastasis, if you cannot assess the metastasis, we use MX. M0 if there is no metastasis, and M1 if metastasis is present. So that is TNM classification. But you can also stage clinically. This is according to American Clinic of Oncology. They just group patients into 2 groups, under 45 years old and over 45 years old. And if you find any if you find any tumor size and any lymph node involvement, but there is no distance metastasis, there is no any metastasis, let's say M0, we could stage 1 in under 45. If there is any tumor size, any lymph node involvement, and there is a distance metastasis, we stage as 2. Remember, in under 45, you're not having 33 and 34, but in the over 45, we're having 33 and 34. That's if you're having T0, N0, M0, or if you're having T, N1 or MO, that is 33 in over 45 years old. If you're having NT, NN, or NM, it is 34. Yeah, that's how it is. So how would you treat the thyroid cancer? So the treatment of the thyroid carcinoma, it depends. Thyroid cancer, it depends on the type of the cancer, its differentiation, and the stage of the presentation. And we generally grade them into low risk and high risk. Who are low risk thyroid cancer patients? Those low risk thyroid cancer patients are the female patient who are having less than 50 years old, or the male patient who are having more than 40 years old, or the patient who are having papillary carcinoma, follicular carcinoma, with a tumor size less than 1.5 or 2 centimeter, or who are having a tumor which is confined to 1 lobe, or there is no distance, there is no any metastasis. So for these patients who are having low risk, surgical intervention for low risk cancer is lobectomy or near total thyroidectomy. But there is a higher recurrence rate with lobectomy, although overall survival between the patient who undergone total near thyroidectomy is not significant to those with lobectomy. So those who are having high risk, like a female patient who is aged more than 50, or male patient who is aged more than 40, or if the patient is having bilateral tumor, or the patient is having metastasis, or patient is papillary carcinoma, which is extrathyroidal, or follicular carcinoma, which is widely invasive, or medullary carcinoma, we all consider this as a high-risk patient. So for this, the management of them is just do total thyroidectomy or near total thyroidectomy with neck lymph node excision. We call it modified Ladi-connected dissection. Yeah? It is followed by postoperative by thyroxine 100 microgram per day to suppress TSH in a patient with thyroid hormone-dependent thyroid cancer. Specifically, we're talking about papillary and follicular cancer. Something to note, this medullary carcinoma is either TSH dependent, nor radioiodine sensitive. So the suppression of TSH reduces the risk of recurrence and also improves the survival. Likewise, radioactive iodine 131 can also be used postoperative to ablate all the metastatic cell or tumor cell left during surgery. And also, a period of hypothyroidism is achieved by stopping thyroxine for a month to increase the tumor cell sensitive to radioactive iodine. For those with poor differentiated, or we call it anaplastic carcinoma of the thyroid, surgery or total thyroidectomy can be tried if the patient is present with LA. This should be followed by the chemoradiation. In advanced case, chemoradiation is mainstay treatment. Yeah? If they come early, then total thyroidectomy. If it's an advanced case, then chemoradiation is the mainstay treatment. Yeah? So the prognosis of thyroid cancer. So the prognostic indicator in a patient who are differentiated thyroid carcinoma is 10 years survival. For middle-aged adult is about 8 to 95%. 5 to 20% have local or regional recurrence, with 10 to 15% have distant metastasis. The main survival determinant includes, now this is the determinant to survival, the main survival determinants. If you're having age more than 45 years old, the growth or the type of the tumor itself, based on the pathology or differentiation, the extent of the tumor, if it's miglobe, is widely invasive, the size of the tumor less or more than 1.5 centimeter, if there is a presence of metastasis and the completeness of surgical removal. So these are our references. Thank you for listening.
Thank you for that presentation. I think you need to post it to individuals, including myself, because I base your presentations to eventually know what topics and we have covered and to what extent, in order to set my exams. So you should send them on our WhatsApp, and we need them. So I wish to thank the two presenters for the elaborate presentation you have made. And I pray that you people are doing thyroid surgeries. Are you?
We have one for Thursday, and yeah, we have one this Thursday.
That is Hoima.
No, this is Ginger.
Okay. How have you prepared the patient?
We have done ultrasound scan. We have done X-ray, both chest X-ray and neck X-ray. We have done fine needle aspiration, and now he's on carbimazole.
So you are going to operate on a toxic patient?
No.
Why is he on carbimazole?
He's on carbimazole because we want to make him euthyroid.
Yeah, that is why I asked the question. Why is he on carbimazole? Has he been toxic? Has he been having hyperthyroidism?
Initially T4 and T3 was slightly high.
What was the TSH?
TSH was low, but then
What
T4 and T3
do you recall the level of the TSH? Was it 0.01, 0.05?
Not of head.
We didn't record, but was a little bit down.
So have you done the latest TSH T4?
Yes, we expect to do it tomorrow.
When is the surgery?
I don't think
The
it will
surgery is
depend with the
supposed
results.
to
Yeah?
be Thursday if the results are normal.
No, that patient is not ready for Thursday.
Yes.
When you deal with a patient who has been toxic, you bring to a euthyroid state, that is, this TSH4 should be normal. Then you give the patient Lugol's iodine for 2 weeks before you take the patient to surgery. Otherwise, you're going to have a lot of bleeding during surgery. The Lugol's iodine helps reduce the vascularity because in hyperthyroidism, there is increased vascularity to the gland. One of the clinical assessments you should always do is to listen. You put your stethoscope at the site of the superior thyroid artery and vein, and you hear a bruit showing that there is increased vascularity, increased blood supply to the thyroid gland. So if the patient is now euthyroid, you start the patient on Lugol's iodine and you keep listening. After 2 weeks, that bruit reduces. That means your patient is ready for surgery. But we normally give it only for 2 weeks and then schedule the patient for surgery. Otherwise, if you prolong the Lugol's iodine treatment, then you're going to get iodide-induced thyrotoxicosis. Okay? That is the Jade-Bezold's reaction. So go back to your patient, reassess, and see that you have prepared this patient properly for surgery. Otherwise, you are going to have a mess during that surgery, and you will not appreciate the operation. Okay?
Okay. Thank you.
What about other centers? Any center having thyroglosal cyst or also thyroid? Okay, any questions to the presenters?
Okay.
Members, you've been listening. You are 11 right now, including me. Do you have any question to the presenters? Another thing I need to mention is when you do radioisotope scan, and if you find time to pass in Kampala, you can ask me and we go with you to the nuclear medicine at Mulago. And you see how they do it with technetium 99. They don't use iodine 121 or iodine 123. They use technetium 99. And then you inject, and then the patient, it goes to the thyroid gland. Now, a cold nodule is not necessarily that solid thing. A cold nodule may indicate, one, there's hemorrhage in the gland, which shows that there's a hematoma there, or two, there's a cyst, or three, it is a solid lesion. Of course, with the complementary ultrasound of the thyroid, then you know that it is cystic or solid. And so, you know, a cystic lesion may be that hemorrhage or it may be a fluid. So not all cold nodules may have a high chance of malignancy unless they are solid, okay? A solid nodule.
Yeah.
So that is when you need to do a fine needle aspiration in this solid and cold lesion. There's a 1 to 10% chance of it being malignant.
Okay.
Then there was a mention of hot nodules I'm happy you said they are usually innocent, but occasionally, in less than maybe even 1%, you may find a hot nodule that is actually malignant. I got one case who had a very bad hyperthyroidism, and yet she also had follicular thyroid carcinoma. So some of those hot nodules in very rare situations may be malignant. Then when you talk about follicular thyroid carcinoma as compared to follicular adenoma, you need a fine needle aspiration will not give you a definite answer. You need core biopsy, because what you want to demonstrate, or what you want the pathologist to demonstrate to you, is capsular and vascular invasion. Once there's capsular and vascular invasion, you only mentioned capsular invasion, but it should be capsular and vascular invasion. Then you know that this most probably is follicular thyroid carcinoma. And also the age matters. Below 40, you'll get papillary thyroid carcinomas. 40 to about 60, in fact, 50 to 60 years, you get follicular thyroid carcinomas. Usually they are in long-standing goiters. Then above 60, then you get anaplastic thyroid carcinomas. So the age matters. Below 10, you may think of medullary thyroid carcinomas, especially when there is a family history of thyroid carcinoma. And if the result comes back as medullary thyroid carcinoma, and if you're in a good center, which may you are able to do the genetic marking, and you find that it's positive, then you have to do a prophylactic thyroidectomy in the children in that family before they reach the age 10. Some literature talk about age 7, but it is important to do the thyroidectomy before the age 10 so that they don't develop medullary thyroid carcinoma. Then, when you talk about surgery and you are writing your notes, I would wish that you are as descriptive as possible. Thyroidectomy can be just a lobectomy. This one can be done for a solitary thyroid nodule. You may do a lobectomy, or what we do commonly these days is lobectomy and isthmusectomy. You remove both the lobe and the isthmus, because should this patient have a recurrence in the future, you don't want to go dissecting the isthmus over the trachea. You need to remove the isthmus at the first surgery, so that should you have a recurrence many years down the road, or should the result come as papillary thyroid cancer, and you want to do a completion thyroidectomy, you only go to one side. You don't have to go start scratching with the trachea and disturbing the tracheal cartilage. So the simplest is lobectomy, then lobectomy and isthmusectomy. Then, following that, you can do what we call, in some books, they may talk about extended lobectomy and extended isthmusectomy. Extended isthmusectomy would mean that you are removing a bit of the contralateral lobe, but that is only used in some centers. But otherwise, they talk about near total thyroidectomy. And near total thyroidectomy, one may do it both for benign and malignant conditions. Near total meaning you are removing one lobe which is affected, the isthmus, and nearly all the contralateral lobe, leaving only very small thyroid tissue or capsular tissue on the contralateral side to reserve the parathyroids on that side. Then after that, you have total thyroidectomy where you're removing everything, then total thyroidectomy and neck dissection. Currently, we don't commonly talk about subtotal thyroidectomy because subtotal thyroidectomy in the past used to be done for hyperthyroid cases. Subtotal meaning on either side you are leaving some thyroid tissue, both on the because usually in hyperthyroidism you find a diffuse enlargement of the thyroid gland. You leave a bit on, say, the left and a bit on the right. That is a subtotal thyroidectomy, removing the rest of the thyroid, including the isthmus. But these days we commonly do more of near total because you live on one side and you don't want to go on both sides in the next operation. Then you talked about radioactive iodine. Yes, radioactive iodine goes and ablates the whole thyroid gland. You just don't give it anyhow. We use it to treat hyperthyroid cases and it is very important to select your patients because you don't want to give it in young adults who are maybe still in their reproductive age. They have not yet gotten children because sometimes it does not select the thyroid gland. I've seen a number of young adults suffering in the future to get children after a dose of radioactive iodine. So it is best to be given in people who have finished their families, especially in hyperthyroid cases. And then you can give it as an ablative dose, a higher dose after doing your total thyroidectomy. Then it goes for the whole cancer. But you would not wish to just give it anyhow to shrink a diffusely enlarged thyroid gland. You would rather give the patient low dose of thyroxine for a period of 6 months. You repeat your ultrasound at 3 months, then at 6 months. In 60% of the cases, the thyroid gland will shrink and you may be able to stop the growth. However, once there are nodules, you know that when the nodules form, that is already an irreversible change. You may not be able to cause adequate shrinkage of the gland once nodules have formed. So you may try, but you tell the patient that you are just trying, and then you do ultrasound, see if there is a reduction in size, do another ultrasound after 6 months. After 6 months, you know, chances of responding are not there anymore. You stop the thyroxine. You don't give it forever. Usually try it for 6 months only. So any questions?
Me, I wanted to ask you, that's what you said that in Kampala, there is a center they're doing this by using iodine 99 rather than 131. Is it, do there any specific reason why they're not using 131? Or is it because of availability?
No, they use technetium. It acts in the same way. It is taken up by the thyroid gland. Technetium 99. Then radioactive iodine is used for the patients who have hyperthyroidism and post-total thyroidectomy for the cancers. It's not that they don't have, but it is better. It is less because the half-life is very short, and then you don't have to isolate the patient once you use technetium 99. But it may be a technetium 99 labeled radioactive iodine, but commonly we use technetium-99 for the different studies, and we leave radioactive iodine for thyroid ablation.
Okay.
Because it is more dangerous. Because once you give radioactive iodine to a patient, you must isolate the patient for 2 weeks, especially when you give it malignant after a total thyroidectomy for a malignant disease. Isolate the patient for 2 weeks. She or he should be away from children, away from pregnant mothers, away from everybody, because he's dissipating radioactive iodine. So you have to be isolated, which for technetium 99, you don't need that isolation.
Thank you.
Any other question?
Yes, Professor, good evening.
Good evening.
Yes, mine is, we are in Kradongo, and we may not have access to do more of those cases of thyroidectomy. We don't know whether when you have those cases like in Kampala where you are, and you could we could request on ground and ask you.
Okay, I may do one on Thursday next week.
Yes.
The patient is going to confirm on Monday. So if you keep track, we can liaise for Thursday next week. I have a case.
Okay, thank you very much. We shall communicate to our doctors on ground consultants earlier, such that they are aware that on Wednesday we shall be traveling now. We shall join early morning. We shall be there for the operation.
Okay.
Okay, thank you, Professor.
Any other? So if there are no any other, I see a chat. I didn't put in the chat. Okay, it's just thanking the team for good presentation. So please post it to the different WhatsApps, including mine, because I base that in setting exam questions. I don't set what we have not covered, because I don't want to be tomorrow cornered by you people and shot at. You people, Gen Zs are now a very difficult group. I don't want to be beaten. Okay, so post it. Yeah, so your group leader will let me know when we can have another presentation, and then he will inform the whole team. Otherwise, I wish you the best. Have a good evening.
Thank you. Thank you.
Bye.